for joining us today on our webinar on coverage for tobacco cessation treatment. I'm Kerry Cork, a staff attorney at the Public Health Law Center and Tobacco Control Legal Consortium. We have a lot to cover today, so I'm going to keep my opening remarks very brief. I'd like to start by mentioning that this webinar is sponsored by the Public Health Law Center's Tobacco Control Legal Consortium, our national network of legal centers and attorneys that support tobacco control policy change at the local, state, and national levels. We do this by providing free legal technical assistance to tobacco control advocates, public health professionals, local and state health departments, coalitions, government and private attorneys, and individuals. Our legal TA includes providing educational resources and trainings, such as this webinar today. So why are we offering this webinar? Well, although more than 51 million Americans have successfully quit smoking and former smokers now outnumber current smokers in the U.S., many tobacco users face barriers in accessing cessation treatments that are covered by insurance as a preventive service. Today's webinar will shed some much-needed light on what tobacco cessation treatments are covered under different types of insurance. Probably the main reason we're offering this webinar is the recent updated recommendation by the U.S. Preventive Services Task Force regarding the importance of a comprehensive tobacco cessation benefit in improving health. How significant is this recommendation? What is the USPSTF anyway, and how can national, state, and local groups use this recommendation to implement comprehensive tobacco cessation coverage? Fortunately, we have three experts on tobacco cessation coverage who will answer these questions on our webinar today. Angie Giulio, Erika Sward, and Shelley Kaiser, all from the American Lung Association. Our first speaker is Angie Giulio, who is the American Lung Association's Manager of Lung Health Policy and manages the Lung Association's tobacco cessation policy work. She's responsible for providing technical assistance to the field on tobacco cessation issues, developing resources and publications, and managing 2 federal grants related to the Lung Association's work on tobacco cessation. Our second speaker is Erika Sward, who is ALA's Assistant Vice President of National Advocacy. Erika directs advocacy strategy and activities on tobacco control, lung health policy, and other issues for the Lung Association. She serves as ALA's lead lobbyist with Congress and the administration on tobacco, appropriations, and lung disease and lung health issues. Erika also oversees federal advocacy outreach, including grassroots lobbying and coalition partnerships, and provides strategic advice on state and local initiatives. Before she joined ALA's national office in D.C. in 2006, Erika served as Associate Director for Advocacy at the Campaign for Tobacco-Free Kids, where she worked mainly on advancing federal legislation and policy. Our third and final speaker is Shelley Kaiser, the Director of Advocacy for ALA in Michigan and Ohio. Shelley is responsible for federal, state, and local lung health, tobacco, and clean air advocacy campaigns in Ohio and Michigan. Her current projects include advocating for tobacco prevention funding in the state budget, reducing smoking in people with mental illness, protecting the Clean Air Act, and supporting renewable energy standards. Shelley has worked for over 20 years in advocacy, public relations, and communications for nonprofit, private, and governmental organizations. She's helped pass smoke-free laws in cities around Ohio and has worked with partners to adopt model tobacco-free campus policies for public K-12 schools and public colleges, raising the state tobacco tax and promoting Ohio's smoke-free casinos. Just a few words before we get started. As I mentioned earlier, the consortium provides legal technical assistance on a variety of tobacco-related issues and works with states and local communities to advance tobacco control. The policies and interventions we support all fit within the World Health Organization's EMPOWER framework of proven strategies to reduce global tobacco use. Today's webinar focuses on tobacco cessation assistance, which is often the end point of our legal policy and intervention assistance. And if you think of it, the term tobacco control is a bit of a misnomer. We're not in the business of merely controlling tobacco use, but preventing it and doing what we can to end its use altogether. We can do that by supporting comprehensive, barrier-free health insurance coverage for smoking cessation products and services. This is particularly important given the impact of cessation treatment on tobacco users and the disparate impact of tobacco use on vulnerable populations, such as those suffering from mental health or behavioral health issues and those of low socioeconomic status. Unfortunately, knowing which tobacco cessation products and services are covered under insurance is often trickier than it seems. Our webinar today is designed to provide some clarity on this extremely important issue. As Ward mentioned earlier, we'll have a Q&A session at the end of the webinar. Please use the Q&A box at any time during the presentations to submit your questions. So we're now going to hear from our first speaker, Angie Giulio.
Thank you, Kerry. Thank you so much for having us on the webinar. We're really excited to talk about this great issue and really important issue. As Kerry said, my name is Angie Giulio, and I'm the Manager of Lung Health Policy here at the American Lung Association's National Office in Washington, D.C. And I'm going to talk a little bit today about what the USPSTF Recommendation for Tobacco Cessation is and what it means. And before I get started, I'm just going to go over a little bit of alphabet soup. We like to use acronyms a lot, and I apologize because I don't think everybody knows them. So we're going to go over them quickly, and we'll try to define them throughout the presentation. So first is ACA, or the Affordable Care Act. You may have heard it colloquially referred to as Obamacare, but we will be referring to it as ACA throughout the presentation. AHRQ, or AHRQ, is the Agency for Healthcare Research and Quality. CMS is the Centers for Medicare and Medicaid Services. This is the agency that governs the Medicaid program, including Medicaid Expansion at the federal level. When we refer to an exchange, that's going to be the state health insurance marketplace. We are going to refer to both exchanges as both the state-run and the federally run exchanges interchangeably in this presentation. FDA is the Food and Drug Administration. HHS is the U.S. Department of Health and Human Services, and this is the agency where CMS lives and AHRQ lives and FDA lives. Labor was the U.S. Department of Labor. And the U.S. Department of Labor regulates self-insured health plans. Treasury is the United States Department of Treasury. And USPSTF, our favorite acronym today, is the United States Preventive Services Task Force. And again, we'll try to sprinkle these in, the definitions in throughout a little bit. And now I just want to take a quick moment before we kind of dive into the meat of USPSTF to kind of go over who still smokes. And this is some data from a November 12th MMWR, or Morbidity and Mortality Weekly Report about current U.S. adult smokers from 2005 to 2014. And as you can see, it looks like some of the values didn't quite show up, but I will go over a couple of them. So the overall smoking rate is about 16.8%, which is really great for adults in the U.S. smoking cigarettes. But unfortunately, when you break it out by things like education level, you see some really great disparities, and I think that's why that highlights the need for this USPSTF. So if you look at members of the population that have attained only a GED have a smoking rate of about 43%. Now, when you compare that with people who have a college education, that bar is 7.9%. I'm not sure if you guys can see that or not. So just really great differences. There's also differences by race, by geography, and then by insurance type, which is what we're here to talk about today. People on Medicaid, and this Medicaid number does include those people on Medicaid Expansion in 2014, smoke at a rate of 29.1%. If you compare that to people with private insurance, that's 12.9%. The uninsured population smokes at a rate of 27.9%, and a lot of that population hopefully will be getting insurance soon. So I'm just going to go on to the next slide real quick. The U.S., what are preventive services? And we know that the Affordable Care Act focused on prevention, and one of the main focuses of prevention was covering preventive services at no cost sharing in various plans, and those plans include most private plans, all exchange plans, and all Medicaid expansion plans, and with no cost sharing. So that means no copay, no coinsurance, or no deductible. Examples of preventative services include routine immunizations, preventive services for youth and children, preventive services for women, and any service that has been given an A or a B grade by the United States Preventive Services Task Force, or the USPSTF. So, what is the USPSTF? The USPSTF was created in the mid-'80s, and it's an independent volunteer panel of national experts on prevention and evidence-based medicine. They make clinical recommendations about preventive services, and these services could include counseling, screenings, anything in that nature, and then they're given a letter grade. And they get, similar to grade school, an A, a B, a C, a D, or an I. An I means there's insignificant and not enough evidence to give a grade. So that evidence is still under review. An A or a B is there's a good reason to do that intervention. And then a C or a D means that it's not good to do that. Since 1998, the USPSTF has been supported by ARC, and they submit an annual report to Congress every year identifying evidence gaps so they can make better recommendations in future years. And as I mentioned in the previous slide, the Affordable Care Act elevated the USPSTF because all of the recommendations that have received an A or a B grade are required to be covered with no cost sharing for those various plans. And those various plans are most private insurance plans. It doesn't include exchange or grandfather plans, but most other private insurance plans are required to cover these treatments and these interventions with no cost sharing. Any plan sold in the exchange, small group and individual plans that are not grandfathered, and any Medicaid expansion plan. There are different requirements for Medicare plans, so that's anyone over 65. Traditional Medicaid plans, so that's going to be the poorest of the poor, whatever the population of Medicaid was prior to the enactment of the Affordable Care Act, and then any grandfathered plan. However, we do know that the number of grandfathered plans are shrinking continuously. Okay, and then what is the USPSTF recommendation for tobacco cessation? And as I said, this is a clinical recommendation. It was updated on September 21st, 2015. There's an A grade for all adults to receive all 7 FDA-approved medications. So that's going to be the NRT gum, the NRT patch, the NRT lozenge, NRT inhaler, NRT nasal spray, bupropion and varenicline. And I realize there's a couple acronyms I didn't define. NRT is nicotine replacement therapy. Bupropion is also sold as
Wellbutrin.
No, that's
okay. Sorry.
Sorry. Bupropion, and then varenicline, which is also sold as Chantix. So there are a couple of different things, and then it also includes all 3 forms of counseling. And then there's an A grade for all pregnant women to receive all 3 forms of counseling. And it's really important to note that the one significant change from the previous USPSTF recommendation to the new USPSTF recommendation is it's very clear in that all tobacco cessation medications and all 3 forms of counseling should be offered, not in either order. So with that, I'm going to turn it over to Erika Sward.
Wonderful. Thank you, Anne, and it's a pleasure to be with everybody today. So now what? I mean, Anne's presentation summarized that the Affordable Care Act requires tobacco cessation coverage for almost all Americans who receive private insurance. But how do we take what a long federal law says, couple that with recommendations from the U.S. Preventive Services Task Force, which focuses on clinical care, not on insurance coverage, and make sure that everybody comes out of it with access to quit smoking? Well, there have been problems with that, and so we were going to talk a little bit about that in the background. So the Affordable Care Act was, as you know, first passed in 2009, and we immediately saw some challenges in making those gaps, so from the law to USPS to coverage. And what we found through a number of different studies was that private insurance plans were not covering a comprehensive benefit. And again, you'll recall from what Anne said, that a comprehensive benefit is access to all 7 medications that are FDA approved, all 3 forms of counseling with minimal or no barriers. But that's not what we found, and you can see here the 3 studies that documented some of that right here, that there was really a lack of comprehensive benefits. And what's more is that there was even more confusion. And we know that confusion with coverage and a lack of a consistent and uniform benefit makes it harder for providers to know exactly what their patients have access to, and it therefore makes it harder for providers to get their patients the help they need to quit. So the Lung Association and our partners pushed very hard, repeated letters, comments, and other really encouraging the Department of Health and Human Services, Departments of Labor, and Department of Treasury, which are kind of in charge, the 3 together, of clarifying and providing guidance to insurance providers about what they have to cover and how to translate the Affordable Care Act into health plans. And they've been doing that through the use of FAQs, or frequently asked questions, as we all know. And so there have been a whole host of different FAQs released on all sorts of different areas for coverage, soup to nuts, some on prevention, some on other things. And we finally got one on May 2nd of 2014 on tobacco cessation. And we were very excited because it really did have good outlines of a comprehensive benefit, as you can see on the screen. But unfortunately, it also had some wiggle room in it for plans, both talking about allowing plans to use quote-unquote reasonable medical management techniques, which is an opportunity for barriers. Also, and barriers could include prior authorizations, step therapy, so you have to try and fail on one medication before your provider is allowed to give you another, and the like. And the other aspect is that it included language saying, for example, which really was a signal, unfortunately, that some plans took to say that they did not have to provide what we see listed here for its comprehensive benefit, but instead could kind of pick and choose which medications they wanted to cover and the like. And indeed, the Lung Association released a report in March of 2015 that found very few of the plans that were available through healthcare.gov for the newly insured particularly were offering a comprehensive cessation benefit that was consistent with what was outlined in the FAQ. And that has led to a lot of additional conversations, but it also really underscored the comments that the Lung Association and many of our partners submitted to USPSTF when we had the chance this summer, and that led to that new comprehensive benefit that they, or the new comprehensive recommendation that they released in September. So where are we now? Well, in addition to asking the tri-departments, Labor, HHS, and Treasury, to issue a new FAQ that makes it very clear that a comprehensive benefit needs to be offered by all of these plans that are subject to the ACA and its A requirements. We're also starting to reach out and have done some really good outreach with state insurance commissioners. And much like our federal government and the state governments have overlapping roles, that's again the case with tobacco cessation coverage. And it's one more example of the importance in tobacco control of the joint federal-state partnerships that are necessary to ultimately enact comprehensive tobacco cessation policies that protect our citizens. So state insurance commissioners also have a really important role both in implementation of the Affordable Care Act and specifically in highlighting what a comprehensive benefit means for the plans that do business in their state. And so in addition to health insurance, of course, insurance commissioners also deal with life insurance and fire insurance and property insurance and everything else in their states. But they do have jurisdiction over health insurance. And so one of the things that we've been doing is reaching out to state insurance commissioners to urge them to issue a bulletin or another communication to the plans in their states, clarifying that a comprehensive cessation benefit needs to be offered to people on private insurance in their states. And so what I want to do now is, let's click, and I have a map here, to highlight some of the states that have issued a bulletin or other information. And you can see here, and this is one of my favorite maps, you can see here that there is no requirements for, we don't have our politically divisive red state, blue state here. We've seen some of the best work in South Carolina and in Oklahoma, but also New York State and Washington State. So I love it when we're in purple territory, and this is a really good opportunity to reach out to insurance commissioners, work on things on a bipartisan basis or a nonpartisan basis, recognizing that the bottom line is that it is in every state's interest that smokers have access to a comprehensive quit smoking benefit. And this is a great new tool to be able to do that. So with that, I'm really pleased to turn it over to Shelley Kaiser, who's our colleague in Ohio, to talk a little bit about what they have done there.
Hi, my name is Shelley Kaiser, and I am the Director of Advocacy for the American Lung Association in Ohio. And I'm going to talk a little bit about our ongoing attempts to get these USPSTF guidelines covered for insurance companies in our state. And first, I'd like to give you a little background about where our coverage stands in the various insurance for various insurances in our state. For Medicaid fee-for-service, we really have great coverage. They cover all 3 forms of counseling and medications. There is a $3 copay for medications, which is disappointing because most medications don't have a copay for Medicaid fee-for-service, so that's just a little hiccup there. Medicaid managed care varies. Prescription drug coverage is pretty good for all of them, but counseling is just so-so. Some of their case managers provide counseling and they might not have the correct training, so that's a problem we have. For both of our Medicaid fee-for-service and managed care, we have a problem with promotion, so even if we have available, the services providers often don't know they're available, so they're not being utilized at the rate that they should be. For our marketplace, insured through marketplace and through employers, coverage really varies widely, and it doesn't conform to those guidelines, the USPSTF guidelines we just heard about. It's often not being provided at no cost, which is what it's supposed to be according to the Affordable Care Act. So we really wanted to see if we could get that coverage that the people in Ohio need, because we have, as a lot of the Midwest, pretty bad smoking rates. So our first order of business was to get together a sign-on letter to send to the Ohio Department of Insurance. So we did that. We drafted a letter to tell them in this letter what the requirements were under the ACA, and we put a link in there to direct them directly to where those requirements are, so they can see that directly. We added a small amount of state-specific data. We sent the draft letter out to a list. We have about 400 or so people that my partners and I have accumulated over the years of working with people on various tobacco public policy campaigns. And we also partnered with Pfizer. They have a list that they work with on broader health issues related to medication, healthcare access, and things like that. So they sent to that list also. And we ended up, as you can see in that picture, with 41 organizations signing on to support. So we have a lovely logo cloud there of our folks that signed on to that sign-on letters to the Ohio Department of Insurance that we sent them. So here's the list of the organizations that sign on. I'll show you the list. It's a great list of medical organizations. We have what we call tri-agencies, which is the American Cancer Society, American Heart Association, American Lung Association, the health commissioners. We had health departments. We had universities. We had a vocational school. We had behavioral health folks represented, family physicians, the federally qualified health centers, cardiologists, dental hygienists, foot and ankle doctors, osteopaths, pharmacists, public health and public health educators. We had Prevent Blindness. We had a free pharmacy that signed on, hospitals. A union, also an organization, UCAN, is responsible for helping people that don't have insurance. They signed on. So we had a really diverse group that represented a lot of different constituencies. So we were really excited that this diverse group was behind our organizations reaching out to the Ohio Department of Insurance on this campaign. So what we did next is, at the same time, the American Lung Association came out with this report, State Health Insurance Marketplace Plans, New Opportunities to Help Smokers Quit. And it showed whether insurance companies in the marketplace were complying with this FAQ as far as the medication portion of these tobacco cessation benefits. So in this report, it showed that Ohio only had 2 of the 16 companies in compliance with that medication report. So we sent out a press release to the media showing the results of that report, and we got great results. The Columbus Dispatch is our newspaper in the capital, and they did a big story on it, and they didn't even cover the Ohio Department of Insurance's side, which from our perspective was great. And Burr and Hannah are the 2 legislative news services, and so they covered it. And we got public news service that was picked up by 19 radio stations across the state. So we got good coverage of that report and the issue of them not covering cessation services at the level that it should be according to the Affordable Care Act. Next, we set up a meeting with the Ohio Department of Insurance. We met with their second in command there at that agency, and their legal representative and also their policy person. You can see from here we had a really nice representation of groups, the Federally Qualified Health Center Association. The person who represented them was also the former head of the Ohio Department of Health under our current governor. The Ohio State Medical Association came with us, NAMI, which represents behavioral health, and one of the local tobacco control coalitions. We had a couple people there who had really close personal relationships with the people that we met with. I can't say enough about how well these advocates did. They were tireless in not taking no for an answer. They had all the facts with them, and they did excellent. We had these excellent resources. We took a fact sheet about what the requirements are. We have a fact sheet. These are our resources that the American Lung Association has, how to design a tobacco cessation benefit. We took the appendix from the report on state coverage showing exactly where the deficits are for our Ohio's insurers. We gave them a bulletin, a template bulletin, a template press release that they could use. We had the Ohio Department of Health tobacco section offering themselves as a resource to do lunch and learns with insurers, to help with promotions or any other way they could help. So we really had a lot of things to offer the Ohio Department of Insurance. But unfortunately, the current director of the Ohio Department of Insurance, who's also our lieutenant governor, is extremely anti-Obamacare and anti-regulation, and we were told that they are against any regulation of insurance companies and would not do anything to put new regulations on insurance companies. In their mind, they were complying with the law currently, and their only way they could make any changes if we were to make this a big issue. So we went back to the drawing board. So they wanted us to generate complaints or to otherwise make this a big issue. So to try to make this a big issue, we created language to explain about this issue, what was required under the law, what wasn't happening, and how people could make a complaint online. So we asked our tobacco advocates to call their insurance companies to find out if they had coverage, what they were supposed to have, and if not, we wanted them to make that complaint online. We gave them a fill-in-the-blank language to do it. We also made a patient fact sheet so providers could hand that to their patients if they didn't have the coverage they need and ask them to file a complaint. We wanted to track this so that we can return to the Ohio Department of Insurance and discuss the complaints they were getting. But the unfortunate part is, so far I've only had one person email me about this. So I guess lesson learned is, so far, that this is probably too difficult of an ask to do with people for what we're talking about. I assume that that is the problem, because here at the American Lung Association, we know because we send out a lot of emails when we want people to take action, and it's difficult enough when we just ask them to press a button. It basically takes about a minute. So we assume that this is probably just a really difficult ask. Otherwise, we assume that people are doing it and just don't want to do the reporting back part of it. Another thing that I did, there's a health efficiency subcommittee, and it's a traveling health committee that we had, and they were looking to hear about ways to make healthcare more efficient. I thought this tied in really well, so I testified at that hearing about it. So what are we going to do as next steps, since obviously they haven't bended to our will yet? We are planning on, first of all, with Medicaid, we're meeting with the Director of Medicaid to talk about managed care. First, we're meeting with the managed care organizations because we want to get that up to par with our fee-for-service Medicaid, because according to their medical director, they should be at the same level. We're going to see if that works first. But if not, we're going to meet with the Director of Medicaid. And we're asking for the managed care to be covered at the same level as fee-for-service. We're taking along federally qualified health center association, medical association, mental health, and infant mortality. It's pretty well understood here in our state that mental illness and the chronic illnesses associated with it are recognized as cost drivers for Medicaid in our state. Also, infant mortality is a really hot topic in our state, so we want to bring those into the discussion around tobacco. We are also with the Ohio Department of Insurance. We're going to work with some legislative champions and see if they can help us with the Ohio Department of Insurance. And we're looking to do some media advocacy to raise that as a big issue in our state. So we have not got them to comply with us, but we are continuing this effort, and we're going to continue until we get them to work on that. So now I'm going to turn it back over to Kerry.
And thank you, Anne and Erika, as well, for your very informative presentations. A few questions have come in, and while we're consolidating them, I want to point out that we have a few resources on how the Affordable Care Act affects tobacco use and control on our website at www.publichealthlawcenter.org. But I know that ALA also has some resource materials available on its website. Anne, could you just tell us a little bit about how folks can access that information?
Yeah, there's a couple ways. I'm going to give you guys a couple of links, and then I'm also going to give you my email address. And if you go back to the original emails that you should have gotten from Kerry, it's all spelled out, so hopefully it'll be easy. We've got a couple of pages. We've got one page dedicated to a lot of stuff about tobacco cessation and various health insurance plans. That's going to be www.lung.org/cessation-TA. On that website, you'll find some recorded presentations that go into a little bit more depth about health insurance or tobacco cessation coverage and various types of health insurance plans. You're also going to find a resource library with information not only from the Lung Association but from organizations like ours with information about tobacco cessation coverage. We also have some listservs that you can join regarding tobacco cessation coverage if you're just interested in getting more information on the topics either about private insurance, exchange plans, Medicaid, Medicaid expansion, clinical practices, so it's all there. Another website that is more relevant probably to this actual webinar is www.lung.org/cessation coverage. And that website is going to be talking a lot about the USPSTF recommendation. We have an updated fact sheet since the new recommendation was issued in September, and then just some information about how to talk to insurance commissioners about it, how to talk to plans about it, and kind of how to use that to your benefit. And then if you've got additional questions, please feel free to email me. My email is anne.DiGiulio, DIGIULIO, @lung.org. And again, that is going to be that's going to be available to you. And if you've got any complaints, if you hear of anybody that hasn't been able to access that coverage or doesn't have it covered, what we've outlined is a comprehensive benefit that's in one of those plans. So that's most private insurance plans, any plan bought through the exchange, or any Medicaid expansion plan. Please report it to us. We really want to try to get some information that we can show and say that this really isn't being covered, because our analysis have shown that it isn't.
Great, thank you very much. And also, I want to point out, people have asked about the availability of the slides. Both the slides and a link to the recording of this archived webinar will be available in the next 2 days. So it will be on our website at the Public Health Law Center at publichealthlawcenter.org. Now we have several questions that have come in. Here's one. I'm just going to throw it out to the panelists. I am in Missouri and have a Medicaid patient who needs combinations therapy. The PCP wrote her up for a patch but was not able to include lozenges. Is that standard for Medicaid?
Hi, this is Ann. I can take that question. I'm assuming she's in traditional Medicaid, but it might apply to each state. While they're allowed to cover it, they can cover only one at a time. So unfortunately, I think that probably would be standard practice.
And the question is, is her provider willing to submit an appeal in hopes of getting that? And that would be the step that it would take. So unfortunately, that's one of the barriers to care that for all cessation coverage that is particularly problematic. And so again, flagging this for Medicaid is an important thing to do, and seeing if her provider can appeal the decision is also would be a good next step.
Okay, great, thank you. This came in, and it's kind of 3 parts. I'm going to try to read through it. Let's see, I have a tobacco cessation program in Idaho. I educate the participants in use of all 7 FDA meds. I hand out the handout that ALA put out July 22nd, 2014, that outlines what is required. Most of the time, even with that handout, the tobacco users are told by insurers and pharmacies that these aren't covered. This has been a huge barrier to access. Can you suggest how to approach this problem here in Idaho?
This is Erika Sward, and what I would do is I would try to put as many of these together and reach out with some partners to request a meeting with the insurance commissioner in Idaho. And it is, for those concerned, it's not a lobbying meeting. It can be done from at least the perspective of state employees as a way to provide context and education. And if you want to have a partner from one of the groups come with you to make the ask, then that can be done too. But essentially what would be very helpful here is to have this flag for the insurance commissioner in hopes that a consumer bulletin can be released and there can be greater education for and also enforcement for the payer.
And this is Shelley Kaiser. I would also ask your patients to submit through their online website complaints that it's not covered, because as we found out, the insurance commissioners are very aware of what complaints they get through their online submission forms.
One more thing on the complaints, just real quick. We know, I mean, this is in many ways, you have people who are insured for the first time, and when they're denied access to something that they thought was covered, it can just really result in throwing up their hands and walking away from it, especially because quitting smoking is hard enough to do. So I think whenever you can document complaints, you should, and Shelley is right, submitting them directly to the insurance commissioner is a great way to do that. But also feel free to push back on the insurance commissioners and say, look, these are people who are newly insured in many cases, particularly through healthcare.gov, the 10 million who signed up last year. And, you know, they are having a hard enough time maneuvering here. We need to give them the benefit of the doubt, and what we really need right now is some additional consumer information in the form of a bulletin, and let's see how things go from there. But I'd encourage a little pushback against this idea that we need to have so many complaints before insurance commissioners are willing to act.
Okay. Great responses from everyone. Here's another question that's come in. Would counseling coverage include counseling by certified tobacco treatment specialists, or would it have to be with an MD, PA, CN, nurse practitioner, et cetera?
Hi, Kerry. This is Angie Giulio. I'm able to answer that question with an actually very unfortunate answer. So unfortunately, it really depends. In Medicaid, and including Medicaid Expansion, it's going to depend on the state. The states are allowed to let certified tobacco non-physician providers be reimbursed for services such as tobacco cessation counseling for both Medicaid Expansion and traditional Medicaid. For that to be done, they've got to go through a process and submit a state plan amendment, and also then, for lack of a better term, turn on the appropriate billing codes for those types of providers, those non-physician providers and non-licensed providers. For private insurance, it's really going to depend on the arrangement or the contract that the plan has with various hospitals and doctors. So unfortunately, it just depends based upon what plan that patient that's sitting in front of you has.
Okay. Any other comments? Okay, we have another question here. It's what if a patient or doctor's office citing the TCA submits a claim for cessation drugs or counseling to an insurer that does not include such coverage in its policies? If the insurer declines, is it violating the law? Must it reimburse?
Unfortunately, that's another it depends. So again, you know, what kind of insurance does this person have? Is it one of the, is it traditional Medicaid? Is it a grandfather plan? Is it a self-insured entity? So that could be a reason for it to not violate the law. For everybody else, you know, whether or not it violates the law is of some discussion, but we certainly believe that copays, charging any copay would violate the law. But in terms of whether or not a company has it covered for counseling, and then ultimately when you would seek coverage for this, for one of the 7 FDA-approved meds at a pharmacy, is certainly troubling, and that's one of the reasons that we're continuing to push for a new frequently asked question document from the administration on this. If this occurs, what I would strongly request is that doctor's office submit and file a claim with the insurance commissioner for the state, assuming that it is in one of the in one of the private insurance that's subject to the A's and B's. And then also give a shout out to the Lung Association, and we'll add it to our list and continue to flag those issues.
Okay, thank you. Any other comments? Okay, I see this is more an observation. It's I work with promoting the guideline to healthcare organizations, both hospitals and clinics. There's a lot of confusion regarding who can provide tobacco cessation services and be reimbursed. For example, physicians, mid-levels, RNs, and non-physician providers. Just just a comment. I don't know if anybody wants to.
Kerry, I can kind of just comment back on that. That's going to go back to that question. This is Ann again, so I apologize. That's going to go back to that idea of who can bill for it. So again, for Medicaid plans, traditional Medicaid plans and Medicaid expansion plans, that's going to be a state decision, and you are seeing some states allowing for that. And there is the state plan amendment process that needs to happen to allow non-physicians to be able to reimburse for that, depending, and then actually, again, turning on those codes. And for private insurance plans, it's going to just be the design of the plan. And so unfortunately, there's not really a requirement there. So unfortunately, there's not a great answer. But it is going to just kind of depend plan to plan, Medicaid program to Medicaid program, state to state.
Okay. Here's another question. Do insurance personnel have reservations about the words recommendation versus requirement when it comes to cessation coverage?
This is Erika. I would say yes. I defer to Shelley in a second if she has anything to add here. You know, how the Affordable Care Act is being implemented, how enforcement is occurring or not occurring, what the role of the federal government is versus what the state government's role with enforcement from insurance commissioners and further clarification. It's still a little bit of a mess, frankly, and of course that leads to confusion, and confusion means that it's harder for smokers to get the access to this comprehensive benefit. So, you know, the Lung Association is really working very hard with our partners to try to alleviate as much of this confusion and really work towards a comprehensive cessation benefit that is clearly defined and clearly outlined, both for healthcare.gov and for Medicaid expansion and for private insurance plans, but also then in every state for traditional Medicaid. And I'm hoping that some of the really good questions that have been asked here today really help clarify why the tobacco control community really needs to work together to move forward to a comprehensive benefit that's as consistent as possible. Because imagine, as we're confused with all of this access that we have for our community, what smokers must feel like when they're trying to navigate this, particularly if they're newly insured or aren't quite used to this process. So I think we still have a lot of work to do, but the bottom line is that you know, we want to work with plans and work with payers so that they understand that how important a comprehensive benefit with no barriers is, and I'd encourage you to take advantage of those opportunities to have discussions and help them understand why that's so important.
Okay. Thank you. Okay, these are wonderful questions. What do you see as the overall impact of the ACA on state cessation quit lines?
This is Ann. I can try to answer that question. So one of the, forms of counseling that's required is phone counseling, which the quit line would be. So, there could potentially, and I don't know this for sure, I'm kind of just speaking off the top of my head, so please apologize for this, but, there could be more partnerships between state Medicaid programs and the quit line. Hopefully more Medicaid match happens for both. Again, this is a little bit off topic, but for both traditional Medicaid and Medicaid expansion, and additionally, potentially some partnerships between some private insurance plans and their quit lines. So hopefully it's strengthening of the quit lines.
And we would certainly refer anybody with quit line questions to Linda Bailey with the North Atlantic or North American Quit Line Consortium. And Linda works very closely on all of these issues and really is looking forward, because there now are opportunities for state Medicaid programs to collaborate with state quit lines and provide some of those resources that quit lines really need to be much more effective and available to the broader population. So, that's another aspect that Medicaid can choose to do, but not enough have done so across the country.
Okay, thank you. Here's a question. What can states do to make sure these requirements are implemented within the self-insured market, which is not regulated by the state? Is there any work being done around this at the national level?
You know, that's a very good question, and I'm struggling with it a little bit. Maybe that is something that we could be emailed to Ann offline, and we can work on following up. The self-insured market, my understanding is that it's getting a little bit smaller because of healthcare.gov, and so we need to let us look into that a little bit more, and please email Ann, and we can follow up with you.
Okay, thank you. What kind of group counseling coverages might be covered? Is freedom from smoking covered or the like?
Yeah, no, that's exactly what it is. So it's programs, freedom from smoking would most definitely count as a group counseling session. Any sort of class-based program. Obviously, we like ours, but it doesn't have to be our program.
And often hospitals run these programs, and they can, and also they can work with local businesses to offer them on site at larger companies or places of employment. So this is another really good way to bring classes and bring cessation services to the employer's location and make it and reduce some of those barriers for smokers.
Okay. Let's see here. Is there anything we can do to make sure this is enforced in our state?
I'm sorry, could you repeat the question?
Is there anything we can do to make sure this is enforced in our state?
You can meet with your insurance commissioner and see what the insurance commissioner can do. Frankly, now is a great time to start building those relationships because state insurance commissioners, you know, they generally have, they get the plans from the states, you know, the plans that do business in their states early fall, late summer, early fall, at least for the exchanges for healthcare.gov plans, and they need to review them all. And there's a lot of different things in there in every part, and bringing this to the attention of the staff that look to review plans for compliance is a really important thing. So now is a good time to start to reach out to say, you know, we want to get this on your radar. We want you to first of all issue this bulletin to plans so that they understand how important a cessation, comprehensive cessation benefit is, and then figure out a way that you can move forward together so that there is greater greater coverage of that comprehensive benefit when the plans for next year start to roll out.
Okay, thank you. And this one, I believe, is directed to Ann. You said the preventive services requirement applies to most private plans. What plans does it not apply to?
Great. So there's going to be two main categories of plans that the preventive services requirement does not apply to. First, any grandfathered plan. So those are going to be any plans that were in effect the day that ACA passed. So you're talking about a plan that's, what, 5 years old by now, and has made no significant changes. As time goes on, just because of the nature of insurance plans, those are going to change. Those significant changes are going to happen. I don't have the list off the top of my head, but I'm happy to direct you to resources to figure out what those significant changes are. Additionally, if you have a grandfathered plan, they're required to send you a letter in some documentation that has to be that says that you have a grandfathered plan. The other category of plans that the U.S. Preventive Services Task Force recommendations and the preventive services requirements does not apply to are self-insured plans that are self-administered. So that is if, you know, company XYZ self-insures their plan, and in company XYZ there's a Department of Insurance, or, you know, health insurance, and they actually do all the administrative stuff as well. They don't have to follow the USPSTF or the preventive services requirement. However, I believe most plans that have that do self-insured contract through a third party, so that, you know, assuming that it just appears to the patients that they have a, you know, a normal or a traditional insurance as you or I might have.
Great, thank you. I believe we're just about out of time right now, so I want to thank again our three speakers, Anne, Erika, and Shelley, for their terrific presentations. Thank you all for your attendance and your fabulous questions. They've been very good, and I hope you all have a great day.